Hello, everyone. This is Neil Stone. I'll be moderating this breakout session. We've got Heather from MiraVista, who I believe is on the line. Heather, are you there?
I am here. We've also got Dr. Wheat, who should be joining, and I'm looking to see if his name pops up. I think he was wanting to speak.
Sure thing. So we'll just give a few minutes for people to join and move over from the main room. So give it a couple of minutes and see if Dr. Wheat also joins, and then we'll take it from there. And we'll start with you, Heather. Have you got a couple of slides you'll be presenting?
Sure. Let me see if I can pull this slideshow up.
Yeah.
How's that?
That looks great. That looks right. So there's a slide saying MiraVista Diagnostics Corporate Overview. Is that the right slide?
Yes, with no busyness on the sides.
No, that's just perfect. So I'm going to get started, I think. People may join us later, but I'll let you go ahead, Heather, and you can tell us about MiraVista, and then we'll have some questions and some networking.
Sure. So MiraVista Diagnostics was founded by Dr. Wheat back in 2002. He was a professor and had a clinical appointment at Indiana University for years, and concurrent with an outbreak of histo in Indianapolis from some construction on the university campus, he switched his focus from, I believe, staph to histoplasmosis and developed an RIA that has subsequently undergone several iterations and is an EIA now. As mentioned, initially, the laboratory was a research project at Indiana University, and he privatized in 2002. This is the corporate headquarters just south of the airport in Indianapolis, and about half of the space is dedicated to a clinical reference lab, and then the other half is dedicated to a research and development lab. The initial test offered was an antigen test for histoplasmosis, and subsequently there are antigen tests for histo, blasto, cocci, Asper, and then the commercially available, Asper actually is commercially available as our beta-D-glucan and cryptococcus latex agglutination. There are antibody EIA tests for histo and cocci that detect both IgG and IgM, and then sometime during the third quarter of this year, we anticipate a blasto IgG antibody assay being available. In addition, we offer antibody testing for FID, for histo, blasto, cocci, and Asper. And these same tests are offered for animals as well. As was mentioned in an earlier presentation, we have an antigen test in lateral flow form that's a CE marked device. It's not through FDA clearance at this point, so it's available outside the US. And then within this calendar year, we've added diagnostic testing for pneumocystis, and we're developing a pulmonary pan-fungal PCR test to detect histo, blasto, cocci, and pneumocystis. We anticipate that being available in the fourth quarter, but currently pneumocystis is available, and we've been offering testing services for a few different hospitals. This is a picture of the lateral flow device. And then, as mentioned, there are several different countries where we have distributor engagements. And I believe that the device is purchasable at this point in Brazil and Argentina and Chile, I believe. And for Mexico, it's still going through the regulatory process, but we're being contacted consistently from distributors with interest in other countries. So hopefully that list expands by the end of the year. And then let me see if I can have Dr. Wheat hop on, because he had a couple slides where he wanted to talk about additional research projects.
Yes, I have. There are a few things we're working on that should be available within this calendar year. We're developing second generation IgG and IgM antibody assays, the EIAs, for histoblastococcus. As Heather mentioned, we're developing a fungal pneumonia PCR that includes histoblastococcus, pneumocystis, and then we have an NIH SBIR grant supporting development of a coccidioides cytokine release assay.
Sorry about that. I'll fix that. Maybe.
Next slide. Regarding the new IgG antibody assays, the let me see. That's the blasto, and the sensitivity is 97% and the specificity is 95%. It's in the process of final validation and should be offered soon. We're also developing a IgM antibody EIA to go along with IgG for blasto, and that work begins later this summer. I think there's a I think show me the next slide, because I think that one's, well, let's go back to the last slide. Well, this is all about the blasto, so let's go to the next slide. We're also developing an ammonia PCR BAL panel. Right now, we just have preliminary results for histoblasto, and of the 7 cases, all 7 were positive, and of the 20 controls, 100% were negative. Cocci is not that far along yet. The pneumocystis, where we recently began to offer, and as applied to all the MiraVista services, we report the result the day after we receive the sample in about 90% of cases, the next day in 95%, and the third day in 99%. We're working on an aspergillus antigen EIA that would different from the Platelia assay, and that works not yet complete. Let's see if there's a next slide. I think that might be the last. Well, the Cocci cytokine release assay is similar to the tuberculosis interferon gamma release assay. It's funded by NIH, SBIR, and it can be used to determine the need for prophylaxis before immunocompromise. If they were cytokine release assay negative, then they would be at risk for development of Cocci. We also will use it for determining who needs coccidioides vaccination once the vaccine becomes available for humans. And it can also be used to determine the effectiveness of the vaccine in humans to see if they've developed interferon gamma response. And in the future, it can be used to define the endemic area of Cocci in the United States. On the right shows the interferon gamma response to a coccidioides antigen. So if they're stimulated with PBS in the white bar, it's very slight. With 10 milligrams or 10 picograms of antigen, a slight response, 25, a larger response, 50, larger still. And then in the black that's kind of hidden by the legend on the right, the response is about 350 picograms per milliliter. So we think that this will be implemented probably in 2 years once we've finished the first phase of the grant and proceed to the second phase and then the final phase. I think that's all that I have to present. Any questions?
Okay, thank you so much both for that overview of what MiraVista has to offer. So if anyone's in the breakout room wants to ask a question, if you can raise your hand or put something in the chat, I'll be happy to pass that on. I think I'm happy to kick off actually from my personal experience. I work in London, at University College Hospitals in London. Before I start, I should say I have no conflict of interest at all. I'm completely independent of MiraVista, and I have experience as a user of MiraVista. And I think from my experience, talking to a lot of people, there's a lot of excitement and interest. And we've heard a lot today's session about the histoplasma lateral flow assay. And I see it as both, it's been useful for us. So I think we are just adopting it now to be able to offer the assay in routine use in our setting. And of course, we're a non-endemic setting. So we see histoplasma very, very rarely. We see it occasionally as an imported case, but it has the great advantage that we can do it test by test rather than having to batch it and get a quick result, rather than what we've been doing up till now, which is actually couriering the sample over to Indiana to yourselves. So I think there's a role for it there. And the second grouping where it's causing a lot of excitement are the low resource settings in the Americas and Africa, where there's almost certainly a huge load of undiagnosed histo. So there's been a lot of interest, and I'm sure people out there would be interested. I don't know if there's anyone in the group here who wants to speak directly to this, but how to actually go about getting hold of these lateral flow assays, and an idea really of cost and distribution and the best way to go about getting hold of them, really. I'd be interested in your comments on that.
I would comment that I don't know the exact cost, but I think that our charge is $10, and our profit perhaps is $5 per test. It's more expensive than the crypto, but there's probably 1,000 times more crypto cases than there are histo. So just the volume effect is the reason why we're charging more. The other point that was made in an earlier discussion is the importance of turnaround time. And for specimens from the US, our turnaround times, as I mentioned earlier, is sometimes the same day we receive the sample, almost 95% of the time the next day, and 99% the third day. Our antigen assays are done Monday through Saturday, and our antibody assays are done 5 days a week. So there is a rapid turnaround.
Thank you. I've got a question coming through from Marisa Mseli. She asks, my question is, how does the new EIA for histoplasma and blastomycosis compare to the antigen testing? So I guess perhaps how does the LFA compare in terms of sensitivity and specificity to the EIA? And if they're available for serum, urine, BAL, CSF, and others. So I'm guessing that's about the range of clinical samples that they can be used on.
You know, I wonder if she's asking about the difference between the MiraVista IgG, IgM antibody assays and the MiraVista antigen assays.
Yes, I'm asking about that.
Yeah.
Sorry, I got confused, but we are pretty satisfied on the performance of the antigens for histo and blasto. And I was wondering what is the advantage of having, having antibodies checked. So
I'm glad you raised the question. Most of the samples we get for antigen are in severe cases, hospitalized patients with disseminated disease. And if they have an underlying immunocompromise, 90 to 95% are positive for histo. If they're not immunocompromised, it might be 70%. And in the patients who don't have severe histo, the antigen is going to be negative, and that's where the antibody comes into the most use.
thank you.
Thank you very much. Anybody else out there with a question? You can either, I don't know if you can raise your hand or just start to talk or put something in the chat. Is there anything you'd like to ask the experts we have here from MiraVista? I think if I can ask a question, if I may, in that case, I'm interested. I mentioned about low resource settings. I wonder if you've had a lot of interest and approach from large parts of Africa and the Americas about getting hold of these, and whether we might, reveal a huge number of previously undiagnosed histoplasma cases in those regions.
Well, there is a lot of interest. There's probably more cases in Latin America than there are in Africa. And I don't know if we have any African, any of the devices placed in Africa or not. We're certainly wanting to offer them there. Deb, do you know if we have any African sites? We've had
answer. I could comment about that. I believe just last week we had requests, the first request for research only devices to evaluate in Africa. I think Ghana might have been listed, and I can't remember the other country, but yes, there have been inquiries.
So my next question will be related to that. Is like, is there cross reactions with the emergomycosis that are described in Africa with like the blasto IgG or the antibodies?
Well, one point I would make is that in Asia, where Talaromyces is common, it's completely cross-reactive in the histo-LFA, and it also cross-reacts in paracoccidioidomycosis. So it's not marketed with those in mind, but it will be useful there. And what was your question about the antibody assay?
No, about the cross reaction, you just answered that.
The cross reactions for the antibody assay, there's a little bit of cross reactivity between histo and blasto, but and in cases where you're not sure what it is, if you test both, it's usually quite a bit higher to the true cause. And it's much less cross reactive with coccidioidomycosis.
Thank you. Anybody else like to ask a question in the chat or speaking? Chris Modi, you've got your hand up. Would you like to ask a question?
Sure. Thanks very much. Can you hear me, Neil?
Loud and clear, yeah. Well, not loud and clear, but clear. So you can go ahead.
Clear. Okay. So Joe, I wanted to ask you a question about the value of EIA for cocci in a patient with a nodule that is being considered for lung cancer surgery and has the appropriate exposure in Arizona. So, and the reason I ask that question is because our local testing seems to be poor in that regard. I see lots of patients that have had nodules resected. They turn out to be cocci, and I do the EIA and it's negative. Do you want to comment on that?
I will. In general, the cocci antigen EIA is less sensitive clinically than the histo and the blasto. All three assays detect 0.2 nanograms per milliliter. In histo, where it's infecting many organs often, it's usually very high. Same is true in blasto. In cocci, it might just be an elbow that's infected. So even though the assay detects the same low analytic sensitivity of 0.2 nanograms, there's just not that much antigen produced in cocci. So in cocci, our IgG and IgM antibody EIA is more useful and should be the assay of choice, except in hospitalized patients that have disseminated cocci. Our IgM antibody and IgM antibody assay are positive in about 90% of cocci cases. And it's more sensitive than immune diffusion or complement fixation. So if I haven't answered your question, please ask again.
Okay, yeah. So what I got was in a patient, asymptomatic patient with a pulmonary nodule that ultimately turns out to be cocci, that patient should have a serologic IgG, EIA IgG should be 90% positive. Is that?
No, I don't think that's true. If it's an isolated nodule, there may not be much active infection going on.
Yeah, so I meant for the serologic response, not the antigen response, but the antibody response.
I mean, even the antibody response is more likely to be, less likely to be positive in that than it would be in a cocci-arthritis or a more significant infection than just a localized nodule. And let me say too, we don't have data on isolated cocci nodules, so I should have the data before I predict what to expect.
Yeah. Can you, I mean, just estimating, can you give me some kind of a number in that kind of setting, an asymptomatic nodule?
Well, I know in histo, asymptomatic nodules are rarely antibody positive. If it's a cancer workup and it turns out to be histo, but in cocci, my impression is they remain culture positive often. And in that case, there could be an antibody response. So I think it'd be worth doing, but if it's negative, I don't think that would mean it's not a cocci nodule.
Yeah, okay. Yep, thanks.
Thank you for that. Anybody else like to ask a question? Either raise your hand or put it in the chat. We've got about 5 minutes. I think just a question from me, I guess going back to the histoplasma lateral flow assay, because that's kind of a new and exciting thing and certainly something I'm using. Currently it's qualitative, so you get a positive or negative, but I know that the assay that you offer in-house gives quantification, which can be certainly useful for treatment response. Do you think it might be possible in the future to have perhaps some kind of semi-quantitative lateral flow assay, which may be useful for, I guess, centers like ours, where we would be using, seeing the occasional case and using the lateral flow assay?
Well, I don't think we've tried to make it quantitative and that really hasn't worked. We've been approached by others about making a device that it would connect to that would give you a quantity. And that's not, we weren't enthusiastic about that. Where it could be used, if it's positive and you treat them and it becomes negative, that's good. And if it stays positive, that's bad. And they may not be getting itraconazole levels, so that there may be a problem with the medications. So it could be followed, particularly if you're concerned about whether the patient's responding or not. We don't have data to show how long it would take to become negative. And hopefully that'll be something that will be done in future prospective studies.
Yeah, certainly that should be my experience with the recent case we had, where exactly that, the patient, it became negative on treatment, and that was certainly reassuring, even though we couldn't get a number to go by. Yeah. So certainly interesting.
One of the other things I think many times in the patients in some of the resource limited countries, eventually they relapse because of not having access to the medications.
Sure.
It would be helpful in those, if they're coming in sick again, to be sure it's histo and not TB or something else.
Sure. And I guess just another one more question for me. I'm stuck on this LFA issue, but that's kind of what I've been thinking about a lot. Has it been evaluated for other sample types other than blood and urine? So thinking about CSF or cytic fluid or pleural fluid or other sample types?
We haven't studied it in those because we don't have those kind of samples. But there's no reason to think that it wouldn't be useful if you had a CSF or some other sterile fluid. Don't say Dr. Wheat said to do that.
Sure. No, absolutely. I mean, I imagine in places where it's, very endemic settings, you see a lot of these kind of patients, I guess would be the places to investigate that. We're going to get a lot of samples. We see a couple of cases a year, literally, of histo. So,
but we're interested in doing studies, and if there were studies put forth from some of the countries where histo is a big problem, we've been able to partner with funding the reagents for the study.
Great. Okay, well, thank you so much to the team from MiraVista. It's been a pleasure to hear about what you offer. And certainly a lot of us are using them now, and I'm sure we'll be able to get in touch with you. I think that wraps up the breakout rooms. So I think in the next minute or so, we're going to go back to the main session to hear Dr. Ostrowski-Zeichner wrap up the day. So thank you very much for presenting, and thank you for attending the breakout room. I hope you've enjoyed the day.
My pleasure. It's really been a nice presentation today.
I agree. Thank you so much, everyone. Bye for now.